Assalamu alaikum and good afternoon, everyone. My name is Abdullah Altaf, and I'm really excited to be here at the 23rd Annual Congress of Pakistan Society of Hepatology to share our research with all of you. So the title of our research is Impact of an Artificial Intelligence-Based Model to Determine Transplant Eligibility for Hepatocellular Carcinoma. So I have only 6 minutes, so I will pace up, so please fasten your seat belts. So before I begin, I would like to mention that there is no financial disclosure or any conflict of interest. So I would like to begin this presentation with a bit of background to our study. For carefully selected patients with hepatocellular carcinoma, liver transplantation is a viable treatment option. Careful selection of HCC patients is therefore the key. And while the Milan criteria are the gold standard liver transplant criteria for HCC patients, a number of expanded criteria and models like the UCSF model, French AFP model, and the moral criteria, and etc. have been proposed over the year to increase transplant eligibility without compromising survival or oncological outcomes. The emergence of artificial intelligence or AI in healthcare has been no less than groundbreaking. Deep learning, which is a newer cutting-edge branch of AI, uses an algorithmic architecture layered like the neural networks of our brain to analyze data. Now, this might sound very complex, but to describe it briefly, what this means is that a deep learning model basically works like the human brain. Just like the human brain, it receives information or data, and it processes that information, picks patterns in that data, and using those patterns, it's able to make predictions when certain input is given to it. The application of AI to select HCC patients for liver transplantation has only been reported recently, as recent as September 2020 in the Moral AI study from South Korea, which showed very promising results. So the primary objective of our study was to develop a deep learning model for the prediction of 5-year post-liver transplant recurrence of HCC. And the secondary objective was to compute the weightages of different parameters in predicting recurrence of HCC after liver transplantation. So basically what we hypothesized was that a dynamic deep learning model can be used to accurately determine liver transplant eligibility for HCC patients on the basis of their 5-year predicted risk of recurrence from our AI model. So coming to the methodology of our study, this was a retrospective cohort study conducted at the Department of Liver Transplantation, Shifa International Hospital. Liver transplant data was analyzed from May 2012 to August 2019, and all HCC patients who underwent liver transplant were included in this study. It is important to note that HCC patients who had macrovascular invasion or extrahepatic disease were excluded. So we included 192 patients in the study, and for the development of AI model, we randomized them into training and validation cohorts with the split ratio of 80 to 20%. 2 prediction models were developed using deep learning. First model was developed using 8 pre-transplant factors, and the second model integrated histological grade as well. There were 8 pre-transplant factors which were selected using filter methods for feature selection. They included age, gender, maximum tumor size, tumor number on CT, number of lobes involved, alpha fetoprotein levels, neutrophil to lymphocyte ratio, and response to taste, which was categorized either as good response or bad response. So as far as data analysis is concerned, we plotted ROC curves, and area under ROC curves was calculated, Kaplan-Meier analysis was done, and also the SHAP or Shapley additive explanations algorithm was employed to compute factor weightages. Coming to the results now, mean age was 52.8 years, median tumor size was 2.7 centimeters, median AFP levels were 15.2, 35.4% of the patients were outside Milan criteria, while 27.6% were outside the UCSF criteria. Median follow-up duration was 59.1 months, and 1 and 5-year recurrence-free survival were 88 and 78% respectively. So coming to the ROC curves now, as we can see in this figure, this is for the AI model without grade. The area under curve for training cohort was 0.864, and for the validation cohort was 0.717. And when we plotted area under curve for the Milan and UCSF criteria, it was 0.646 and 0.598 for Milan and UCSF criteria respectively. So we can see that our AI-based model was superior to these well-established criteria. And when grade was integrated into the AI model, the AUC improved to 0.875 0.5 in the training cohort and 0.771 in the validation cohort. Coming to the Kaplan-Meier analysis now. So based on the AI model predictions, patients were classified either as low risk or high risk to develop recurrence of HCC. For the AI model without grade, in the low risk group, the 5-year recurrence-free survival was 92.6%, and for the high risk group, it was 45%. And on the log-rank test, the p-value was 0.009. And when grade was integrated and we built the AI model for it, the 5-year recurrence-free survival in the low risk group was as high as 96%, and for the high risk group was as low as 30%, and p-value on log-rank test was less than 0.001. Factor weightages, so for the AI model without grade, tumor size, AFP levels, and response to taste were the 3 most significant factors, as shown by their high mean sharp values. And for the AI model with grade, tumor size, grade, and AFP levels were the most significant factor, were the 3 most significant factors. So based on our results, we came to the conclusion that the AI-based model might improve the determination of transplant eligibility for HCC. So yesterday we had very interesting panel discussion on HCC where we talked about tricky situations where decision to move to transplant was very tricky. So we believe that an AI-based model might address that. And not just as a tool to select HCC patients for liver transplant, but our AI-based model can be used to inform patients about the accurate disease prognosis, devise individualized post-liver transplant surveillance strategies, and identify patients who can benefit from adjuvant therapies post-liver transplantation. These are the references for all the cited articles, and thank you so much, everyone.
Excellent. So this is amazing. The artificial intelligence is just the key, and then we are still learning.
Yeah.
So few questions I have that, we have at UCSF the retreat score, which is basically predict post-transplant recurrence, right? And that is based on the factors and very simple score with alpha-fetoprotein at the time of transplant within 3 months. The important thing was whether you had any viable tumor at the time of transplant, although you have the total tumor size, whether there was some microvascular invasion or not. Because on the explant, you will have that data about the microvascular invasion, because those are the patients who have a very high predictor, right? So that score is very simple to calculate. So I would recommend that you should, the technology you have should also run by with the retreat score and predict. Because the important thing is you have these factors, but then what will be the post-transplant recurrence and how you follow those patients post-transplant. Right? So a retreat score has been validated both internally at UCSF and externally now, which has been used all across the US. And then you have to show that it's as good as retreat score or it's better than retreat score, right? So I think that's what I would recommend. Read about the retreat score at UCSF, and then you need more numbers because your study is very small. So whatever you will gonna say, it's hard to prove. So you will definitely need to collect prospectively. The other thing, if you have those biomarkers, because the new thing is alpha-fetoprotein L3 fraction and DCP that have been using more and more, that also. But this is amazing stuff. Keep it going.
Thank you so much for your feedback.
But to publish it, you will need a little bit more. You have to look at the retreat score and everything. The other thing, obviously, in Pakistan, some of these patients does not get treated and they get a transplant, right? So in the US, everyone get treated, and that's where the response to the taste, because some of those patients had treatment and some did not have treatment. So you need to also differentiate in that group. Okay?
Okay, perfect. Thank you so much for your feedback.
Excellent presentation.
Thank you.
Very nice. The only question I had was that 81%.
Sorry?
Out of sample size, 81% were males.
Yeah.
Is there any reason for that?
We just analyzed our database.
In male patients, is that more common in male patients as compared to female?
We can't comment on that because it also, it's also like common for males to get referred to hospital, and so basically I can't comment on that. Is there any association with gender for HCC in Pakistan? We just analyzed our database, and we just happen to have 81% males in our population of patients. So that's it. I don't think we'll need to do another study to find if there's any association between gender or and HCC.
Yeah, I think the HCC itself is more in men. If you look at the overall study, even at the retreat score for external validation, it's about like, average 70% or 65-70% are male.
Okay.
So HCC is slightly more male, although there are many different reasons for that. But also we see it internationally, most of the studies. Yeah.
Okay. Thank you.
Thank you, Dr. Abdullah. Well, it is certainly common in males, but the study was from capital Islamabad, so has to be something,